Hi, good afternoon to y'all. Welcome you guys for a theory session. So today I'm going to do a free session in Obs and Gynae just to initiate the theory course for the new batch. Okay, so again, welcome you all for this new session. My name is Dr. Vasantha De Silva. I'm one of the obstetrician and gynecologists, and I have been an ERPM teacher for a long time. So, right. So, hopefully your exam, next theory exam will be roughly in about May or June. We don't know exactly, but we have to get ready for the exam. Okay. So when it comes to the exam, you all know, for the people who are taking the exam for the first time, you have initially the theory part. Okay. So once you get through the theory part, then you are eligible to get the YY exam. Okay. So that's how the exam goes. And this theory exam, when it comes to theory exam, you need to get at least 45 marks out of 100. Okay, 45 would be the minimum requirement for your this is kind of a selection exam for your the Viva. For the clinical exam, you have to get at least 45 marks out of 100 to become eligible for your Viva exam. So new people, for the new people, right? Just I give some brief introduction about the subject. Okay, just to begin with. But the people who have taken the exam, they know the exam setup and everything. So when it comes to Obs and Gynae, now as far as I know, there are about 4 main subjects for your exam. That is Obs and Gynae, surgery, medicine, and pediatrics. And in addition to that, you have community medicine, forensic medicine, and psychiatry as well. So 7 subjects altogether. So it's not going to be an easy job, because within about 2-3 months time, you all have to get ready for all these 7 subjects. So it's not that easy. If I talk about Obs and Gynae, right? Can you all please switch on your cameras? Thank you. I need to have eye contact with you all, right? I need to know the people, right? So that's why please switch on your cameras, Darwani. So as far as the exam is concerned, Obs and Gynae theory exam is concerned, this is one of the most unpredictable subjects out of all other main subjects. Why I say it's an unpredictable subject? Because time to time, Obs and Gynae would be the rate limiting factor, or would be the determinant factor of your theory exam. That means if you take surgery or any other main subject, right? The exam format is almost always the same. You get lots of previous questions, past questions, and the exam format is almost the same. The content also, there is no much of difference. There is high degree of repetition of questions, previous questions. But when it comes to Obs and Gynae, time to time, they make the paper different from other subjects. They change the format completely. Okay, so because of that, this is one of the subjects that will determine your success in theory exams. This is one of the rate limiting factors. So what I want to tell you all is from the beginning, Darwani, you have to pay the equal attention to all 4 subjects, all 4 main subjects. Some people think that, like, if you take Obs and Gynae, Obs and Gynae is this area. You can cover with a small pen. So they keep studying the other so-called big subjects like medicine, surgery, and all, and they will pay minimal attention on Obs and Gynae. But when it comes to the exam, this is going to be the most difficult, so-called difficult exam, difficult paper compared to rest of the main subjects. If we analyze the data in the previous exam, the most recent exam, okay, the surgery pass rate was about 65%. Surgery Compared to that, if you compare obs and gynae, what was the pass rate? It was below 44%. Okay, the overall pass rate was 44%. So genuinely, the people who came to my class, it was slightly above 49%. But still, it's not great like medicine and surgery and the pediatrics. So this is one of the most of the students find it difficult with obs and gynae because the content in this subject, the content, the content quite small. The syllabus is comparatively small. However, there are lots of new things are there and lots of new terminologies are there. And the subject is completely different from other subjects. If you take the pediatric and medicine, pediatric is like the small version of medicine. Not exactly the same, but there are a lot of similarities. But if you take surgery and obs and gynae, completely different. So what I want to tell you all, Dharwani, in this first day, please pay equal attention on all 4 main subjects. Don't leave everything till the last moment, then you will lose the bus. Okay, so please start doing work from today onward. So today I'm going to discuss with you all a very important topic as far as your exam is concerned, that is infections in obs and gynae. Okay, so infection is one of the main topic as far as your exam is concerned, because you will get at least 2 MCQs from this topic, as well as there can be SBS also, single base type of questions also with this topic. Okay, so if I talk about your the exam, the format, right? You will have, I think most of you guys know about it, right? Just to recap, since this is your first day, you will have 25 MCQs and 25 SBAs. What are MCQs, Dharwani? MCQs means like true, false, like the answers, like they will give kind of a scenario or some information, and they will give 5 statements. They will give 5 statements like A, B, C, D, and E. You have to select whether it's true or whether it's false. True or false, true or false, something like that. So there's a 50% chance. So looks like it's easy because it's true, false. You don't have to think much. But the problem here is that in MCQs, they will give you all negative marks. That means, say for example, suppose there is a question regarding, for an example, PPH, postpartum hemorrhage, for an example. So they have given you 5 statements to select whether they are true or false, right? Suppose you mark like this: true, we say true, 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 all true. Okay. Suppose only A, B, C is correct. This is correct, this is correct, this is correct, but this is wrong, this is wrong. So you get 3 plus marks and 2 minus marks. Ultimately, how many marks you will get for this question? Only 1 mark. You will get only 1 mark. So you got 3 answers correct. However, you will get only 1 mark. So that is the danger, that is the difficulty with MCQs. So base thing is that with MCQs, we will discuss these things later. With MCQs, base thing is don't try to guess too much. If you know 3 answers out of 5 for sure, stop at that level. Don't try for 4th or the 5th one. That is my advice. Because of the negative marks, then you can lose your marks. That is MCQ. You will get 25 MCQs. When it comes to SBS type, what is single base type of questions? Single base type. Single base answers. SBS. Again, suppose they will do another scenario. Usually these SBA questions are clinically oriented, more practical questions. Okay, so they will give a scenario like a patient was taken to the labor room and blah blah blah. CTG is this, vaginal examination finding is this, and they will ask what is the next step of management. Or they will ask what is the best step of management or next step of management. Something like that, they will ask question. And they will give another, like the previous, they will give 5 options currently, C, D, and E. So out of 5, you need to select what is the most suitable answer for that question. Okay, so out of 5, you have to select 1. So this is not that easy. They won't give you negative marks for these SPAs. Okay, but this is unless you have very good theory knowledge. Okay, unless you have very good theory knowledge, unless your theory knowledge is you have a sound knowledge in your theory and in the practical aspect, it's very difficult to answer these SPAs. Okay, so I will train you all how to tackle with the MCQs as well as how to tackle with these SPAs later. So you will get 25 SPAs and 25 MCQs for your exam. Out of everything, out of 100, you need to get at least 45 marks. Even if you get 44, still you fail. Okay, there are a lot of students who got 43, 44, still unfortunately they can't proceed. Okay, so it's tricky that work, right? I don't want to frighten you all, but please keep in mind, exam is not that easy. You have to target for a most difficult one. Then at least if you get an easy one, then you will be safe. Even for a difficult paper, if you know properly the theory, then you can tackle, you can get the answers for any of the questions. So you can ask from the previous students who attended to my classes, right? So I will be doing theory 100% relevant things. Okay, I will make sure that people who are coming to my class, right? So I will arm them with 100% theory knowledge. Okay, so I will discuss everything simply with simple explanations, and I will not, my purpose is to train you all for your exam, ERPM exam, not for a postgraduate exam. So I will not do unnecessary things, only relevant things for your exam. Okay, Daru, so you will understand these things. Simply, I will explain everything. Okay, so without spending much time, we will move on to the topic today, right? Today I'm going to discuss with you all infections in pregnancy. Infections in pregnancy. First, we will discuss about syphilis. 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 Okay, so if you come to this infection, Darwani, what are the things that you need to know? So if you take any infection, you need to know who is the causative organism for this infection. Say, for example, Tarushi, if you take syphilis, what is the causative organism for syphilis? For Swatari. Then what is the incubation period for this infection? And what are the clinical features? What is the effect on the mother? What is the effect on the baby if she becomes pregnant? So those are the things that you need to know regarding any of the infections. So just to begin with, we will start with syphilis. If I share the screen with you all, hope you all can see this. Yes. So syphilis is caused by, you know, there are various pathogens, Darwani. You have bacteria, viruses, spirochetes, amoebae, like that, various organisms, microbes are there. When it comes to the syphilis, syphilis will be caused by, not by a bacteria, not by a virus. It's called a spirochete, Treponema pallidum. This is the organism in an electron microscopic view. Treponema pallidum is it's called a spirochete. What do you want with my spiral? It's a spiral. Like, can you see this picture clearly? It's like a spiral. It's called spirochete. So in your paper, in your MCQ paper, if they say that the syphilis is caused by a bacteria, true or false? It's false. It's not caused by bacteria. It's a spirochete. It's bigger than a bacteria. This is the appearance. Okay. Now, how will you get syphilis? If someone come and touch you, a person with syphilis come and touch you, will you get syphilis? No. If you get a meal, a dinner out, if you go for a dinner out, only for dinner, if you go for a dinner out with a person who is having syphilis, will you get syphilis? No. If you just share your meal, will you get syphilis? No. Syphilis is a sexually transmitted infection. It transmitted via the sexual contact with a person who is having the problem. So suppose a normal person, right, got exposed to syphilis. Okay? got infected with syphilis. When the organisms entered into your body, initially this spirochete can enter into your body and they can cause what is called primary syphilis. Primary syphilis. What is the characteristic feature of primary syphilis, Darwin? Now, Darwin, we all are adults, right? We don't have to be ashamed about these things, right? I hope you all are doctors, so we all are adults, right? So don't look at the picture like this way. Like something like that, right? So you are going to become doctors. So the patients will come to you and discuss these things with your directly. So you have to be confident and you have to be professional. So what is primary syphilis? What is the characteristic feature of primary syphilis, Udari? They will cause a single painless ulcer. This is a painless ulcer. Remember, it's a pain. You know, when you have an ulcer, it's painful. Almost always, when there's an injury or an ulcer, it's painful. It causes some pain. But the characteristic feature of this primary syphilis is it causes a painless ulcer. So you can see it may be on the penis, it may be on the vulva, sometimes it may be on the cervix. Unless your partner is going to be a VOG, nobody will notice these things on cervix. Who's going to look at the cervix other than you are a VOG? So these lesions can pass unnoticed very easily because of the nature of being a painless ulcer. It's very important to remember this is a painless single ulcer. And people in this stage, primary syphilis, are highly infectious. That means they can readily transmit this infection to another person. Highly infectious. Okay, highly infectious. So, if you treat the patient at this stage, what is the treatment for this syphilis? Treatment is good olden days antibiotics, that is benzyl penicillin. Benzyl penicillin is the drug of choice for this condition. If you treat the patient, usually they recover from the infection completely. But if you don't treat the patient, or if this go unnoticed, pass unnoticed, what will happen? After about 6 weeks, this can progress to what is called secondary syphilis. This is the picture of a secondary syphilis. Secondary syphilis will be characterized by generalized macular-papular rash involving everywhere. This is called condylomata lata. Condylomata lata. Okay, so it's called a generalized skin rash all over the body. This is the secondary syphilis state. You had initially primary syphilis. What is the characteristic feature of primary syphilis, like me? It's a single ulcer, painless ulcer. painless though. After about 6 weeks, patient can turn out into the secondary state if you are not going to treat the patient. It is characterized by condylomata lata. Remember, there is another condylomata. Does anyone knows? That is called condylomata acuminata. I'll come to that picture later. Does anyone knows what is condylomata acuminata? Kinkini. What is condylomata acuminata?
What?
Viral warts. Viral warts. I'm happy to see that some of the past students, that means they have already passed the exam, but still they are coming to the class. so condylomata acuminata means viral warts. Condylomata lata means this secondary syphilis. So please remember about these terminologies, these names, right? So in the exam, if it appears as condylomata lata, lata means syphilis. Okay, this is the feature. Normally, when it comes to the secondary stage, like this stage, they can't spread the disease to another person. The disease is inside them, but usually this is not going to another person, Priyanjay. Okay, so this is not infectious. Primary syphilis is highly infectious, but when it comes to secondary stage, it's not infectious. Remember. So suppose if even with this condition, if you have not treated this patient or patient defaulted treatment or due to some reason, if you don't treat this condition at this stage, patient can go into the next step that is called tertiary syphilis. So you have primary syphilis, then you can go into secondary syphilis, then tertiary syphilis. Tertiary syphilis. Before they go into tertiary state, there is an intermediate state called latent syphilis. Latent syphilis means it's not primary, it's not secondary, it's not tertiary either. It is in between secondary and tertiary state. Latent syphilis. Okay. So remember about that name, latent syphilis. There are no characteristic features for tertiary syphilis, latent syphilis. But when you come to tertiary syphilis, what are the characteristic features? What are the, this is again, secondary syphilis, you can see everywhere, face, back of the chest, even the palms and the soles also involved with condylomata lata. This is the tertiary syphilis. When it comes to tertiary syphilis, it is more severe disease. It affects mainly to your cardiovascular system and to your neuronal system, central nervous system. So it's also called neurosyphilis and cardiovascular syphilis. That is the tertiary state. Senthil, can this disease now be infectious? A person with tertiary syphilis, can they spread this disease to another person or to a partner? No. Only primary syphilis is infectious. When we come to secondary and tertiary stages, it's not infectious. You can't spread this disease to another person. However, you are having the severe disease. In this picture on your left-hand side, this is, you can see the heart and the root of the aorta and the aortic knuckle and the descending aorta. So, when you come to the tertiary syphilis, when the cardiovascular system is involved, characteristically, they cause aortic root aneurysms. Aortic root aneurysms. It's a characteristic feature of cardiovascular syphilis. Okay, so very high mortality. And not only that, you can see when you have tertiary syphilis, they can damage your heart, they can damage your neuronal system, as well as they can make you deformed. Can you see these deformities? Would you like to have this kind of faces? Right? It's worse than somebody's, the ugliest face is much worse than that. Right? So these are the features of tertiary syphilis. Then Taru, when the mother having syphilis during pregnancy, what can happen to the baby? When a mother is having syphilis, this infection can transmit it to the fetus inside. So fetus can get abnormalities. Can you see this teeth of this newborn kid? Okay, this is called Hutchinson teeth. Can you see like you know this concave appearance? This is characteristic of congenital syphilis. Okay, characteristic of tertiary syphilis. So they can't smile. The moment when they smile, the people knows that the mother got syphilis during pregnancy. This is a landmark. And also, their joints can be abnormal. These are called gluten joints, abnormal joints. They don't have the sensations on the joints, so as a result, joint can be repeatedly traumatized. And you can see the Shabrishing. Shabrishing means that the bone defects. Okay, bone defects. Sorry. So likewise, the babies can get complications as well as abnormalities when the mother is having syphilis. Okay, this is called congenital syphilis. This is called congenital syphilis. So syphilis, you have primary syphilis, secondary syphilis, tertiary syphilis. In between, you have what is called latent syphilis. Primary syphilis will be characterized by a single painless ulcer. That is also called chancre. Chancre. Because of that chancre. Chancre, primary syphilis. Secondary syphilis will be characterized by condylomata lata. Condylomata lata. Okay. Then you have the tertiary syphilis. It will be characterized by the deformities and cardiovascular involvement and the nervous system involvement. When a mother is having the disease, that can transmit it to the baby, and baby can get the congenital syphilis. As a result, you can get these Hutchinson teeth, gluten joints, Shabrishing, all these deformities. Okay, Ajantan? Right? So, how will you confirm the diagnosis of syphilis? So, if there is an ulcer like primary syphilis, if there is an ulcer, you can take a smear from the ulcer and you can do what's called dark ground examination of a smear. When you do the dark ground examination under the microscope, you can see the spirochete, Treponema pallidum. That is one of the tests. Dark ground examination. How else you can diagnose this infection? There are serological markers that can be used to diagnose syphilis. Serological markers. Some are non-specific, some are specific. Some are non-specific, some are specific. The non-specific test is called VDRL. Venereal Disease Research Laboratory Test. You don't have to remember that long name, just VDRL. So, VDRL is a non-specific test for syphilis. That means that only. In other conditions also, VDR can be positive. That is why it's called non-specific. Even sometimes with normal pregnancy also, this can become positive. When you have leprosy, this can become positive. When you have rheumatoid arthritis, this can become positive. So this is a non-specific test for syphilis. What are the specific tests for syphilis? What are the specific tests for syphilis? Everyone, please switch on your cameras. Right? What are the specific tests for syphilis? What are the specific tests for syphilis? There are specific tests, those are called FTA antibodies, TPHA, Treponema pallidum heme agglutination test. So likewise, there are specific tests. They will become positive only in syphilis, not in other conditions. So you may be wondering, when you have this specific test, why the HELL people are doing this non-specific test? What is the reason? Why the HELL people are doing this non-specific test when you have more specific test? You know, in pregnancy, all pregnant mothers should undergo VDRL test in the first booking visit itself. Okay, we will discuss those things later. Every pregnant mother should undergo the VDRL test to see any evidence of syphilis. But still, it is non-specific. So why you are doing this non-specific test? Dharwani, if you have active syphilis, only VDRL become positive. That means that suppose somebody had syphilis before it was treated. Now when you do VDRL will be negative. VDRL will be positive only if you have the active disease right now. It won't become positive for a previous infection. Okay. What about these tests, FT antibodies and TPHA? If you get syphilis, even in the past, this test can be positive. So once you get the disease, the test will be positive throughout. So it doesn't differentiate whether you had a previous infection or whether you are currently having the active infection. It won't differentiate. It will tell you at one time in her life, she got syphilis. That's all. In she is having a good kalakiriya now. You're not worried about the past, no. So that's why we have to do VDRL. VDRL, we don't worry about the previous things. They will tell only if you have the disease now. Past medical history they don't want. Right? So that's why still people are doing VDRL as a screening tool for syphilis. Remember that. So in the exam, if they say, if the VDRL is positive, can you say she's having syphilis? Suppose I'm a pregnant lady now, right? So you are the doctor after ERPM exam and all, you are now fully qualified doctor, right? So I'm a pregnant lady, I'm coming to your clinic. You do VDRL, I'm pregnant now, okay? You do VDRL and VDRL is positive. What will you tell? Now it is positive. What will you tell? Can you tell the patient, look, you are having syphilis? You can't tell because this is non-specific. Okay, to confirm that thing, so there's a possibility she may be having active disease now. To confirm that thing, you have to do one of the specific tests as well. If that is also positive and VDRL now positive, that means you are having active disease. Okay, so you have to be very careful when you are breaking the bad news, right, with these non-specific tests. Okay, right. Any problem regarding syphilis? What is the drug of choice for syphilis, Dharwani? Penicillin. Any problem so far? Nilanga, any problem, Dharu? Netra, any problem? Okay. Mary Roshani, any problem, Dharu? Okay, right, good. So shall we move on to the next infection? Right? Okay. Next, we will discuss about HIV infection. Okay, right. So, what is the organism responsible for syphilis, Dharwani? Spirochete. It's the Spirochete Treponema pallidum. Not a bacteria, not a virus. Okay, it's a spirochete. So, when it comes to HIV, it's a viral infection. So, what kind of virus it is? Is it a DNA virus or an RNA virus? It's an RNA virus. These are also important. It's an RNA virus. Remember, RNA virus. There are various subtypes of HIV, but basically you have two types: HIV1 and HIV2. as far as the management is concerned, there is no much difference whether you have HIV-1 or HIV-2. A question asked, wait. Sorry. If VDRL is positive, yes. If VDRL is positive, how to exclude other causes? Then you have to do more specific tests. Right? Right. So when it comes to HIV, the HIV-1 and 2 they are RNA viruses. So what is the effect of HIV during pregnancy? What does HIV do to a pregnant lady? Any effect to the mother or any effect to the baby? Remember, HIV does not affect the baby in the sense HIV will not cause deformities of the baby. Now you all know that if a mother is having syphilis, that can cause a lot of abnormalities of the baby. But if a mother is having HIV will not cause abnormalities in the baby. And HIV will not affect the pregnancy directly. Okay, it won't change the pregnancy or pregnancy outcome or anything when you have HIV. So, however, if a mother is having HIV, that can be transmitted to the baby. If a mother is having HIV, unless you treat, there is about 30% chance this infection can go to the baby. That is called mother to child transmission or vertical transmission. From mother to the baby. That is the problem with HIV in pregnancy. The mother can spread the disease to the baby. Baby will not get abnormalities, however, baby will be infected with HIV. Okay. What are the three main ways where the mother can transmit this infection to the baby? One way is through the placenta. Okay, from the mother, while the baby is inside, through the placenta, the infection can go to the baby. That is called transplacental. Transplacental route. What is the other way route? During the delivery, during the birth passage, the baby can get the infection. So during delivery, baby can get the infection. What is the third way? Third way is by the breastfeeding. When the mother does the breastfeeding, the infection can go to the baby. So the main purpose or the main target of HIV management in pregnancy is to minimize this vertical transmission. That means the transmission from the mother to baby, you have to minimize. We know there are three ways it can transmit to the baby. That is through the placenta at the time of delivery and while the mother is doing breastfeeding. So you have three strategies to minimize mother to child transmission. Sahadevan. Right? There are three ways. Yes, good. There are three ways. What are three ways? How you can prevent this infection going from mother to the baby during pregnancy? Can you go and call? No, you can't go and infect the baby. Can you do that? No. How you can prevent? That is by giving drugs. So these drugs are called highly active antiretroviral therapy. So all pregnant mothers, now when when somebody is having HIV, how do they monitor the disease activity? Suppose I have HIV. Suppose I have HIV. So how will you monitor my disease activity? Is by, there are two ways. Viral load. How much viruses I am having in my blood, in my cells. That is called viral load. It's one of the markers. Okay. So if the viral load is low, that means the disease is under control. In that case, some people do not need treatment. Some people do not need antiretroviral therapy. However, if you become pregnant, all pregnant mothers should need antiretroviral therapy starting from 24 weeks onwards. A person who doesn't need therapy by herself, but during pregnancy, you need to put them on treatment. So if a statement says like this, all HIV positive pregnant mothers should be on antiretroviral therapy during pregnancy. True or false? It's true. It's true. After 24 weeks, Netra, everyone should be on antiretroviral therapy. Remember, that is one. And so by their means, you can minimize transplacental spread of the disease. Transplacental spread, you can minimize. Okay, right. What is the next way of transmitting this infection to the baby? It is during the delivery. Mainly, if the mother is undergoing a vaginal delivery during the birth passage, because lots of secretions are there. These secretions contains the virus. So during the birth passage, the baby can get the infection. Transplacental route. So because of that, HIV positive mothers are better delivered by a cesarean section to minimize this content. There are exceptions. I'll come to the exceptions later. Okay. So what I am talking now, Darwane, like me, what we are talking now, Darwo? We are talking mother to child transmission. What are the 3 ways, Ajantan, where the infection can go from mother to baby? Through the placenta, during the birth passage, and after delivery by the breastfeeding. Through the breastfeeding. So you have to give, these are the targets that you have to achieve. So you have to avoid transplacental transmission. That's why you start treatment, chemotherapy. To minimize this contamination during the birth passage, you offer them cesarean section. And finally, breastfeeding usually contraindicate when a mother is having HIV because there is a risk the mother can transmit this infection to the baby. So you avoid breastfeeding. These are the 3 things that you can do to minimize mother to child transmission. There are some exceptions and some things, some points that you need to know about these 3 strategies. So I told you all, every pregnant mother should be on heart therapy at least starting from 24 weeks onwards. Okay, right. Most of the cases we start multiple drugs, not a single drug. You start several drugs together. Multi-therapy. Or sometimes people use what is called sidovudine or sidovudine monotherapy. Sidovudine or sidovudine monotherapy, single agent. Sidovudine monotherapy. If a mother is on these things I haven't mentioned in your handout, please jot down these things, right? If a patient is on sidovudine monotherapy, single agent, definitely these babies must be delivered by a cesarean section. Must be delivered by a cesarean section. Pseudovidin monotherapy, people who are on pseudovidin monotherapy must be delivered by a cesarean section. But people who are on multiple drugs, multitherapy, not like single agent, but various other drug combination, multiple drugs. In that case, when it comes to the delivery, it's not always cesarean section. You check the viral load, or the viral concentration at 36 weeks. At 36 weeks, you check the viral load, viral concentration. If the viral load is below 50, if it is less than 50, they can undergo vaginal delivery with minimal risk. They can undergo vaginal delivery. If the viral load is more than 150, more than 150, definitely they need a cesarean section. 50 to 450 is debatable, but better delivered by a cesarean section. I haven't mentioned those things in your handout, Darwin. Just to keep you all awake, right? Please write it down. So there are three things that you can do to minimize mother-to-child transmission, Darwin. One is the drug. Second thing is the cesarean section. Third thing is avoidance of breastfeeding. However, there are exceptions. One of the points that you have to remember is, so patient is on monotherapy, pseudovidin monotherapy, you can't offer them vaginal delivery. That are high risk. You have to offer them elective cesarean section. Right? If they are on multiple drugs, several drugs together, combined therapy, then not always cesarean section. What you have to do is you check the viral load at 36 weeks. If the load is low, less than 50, so that means you have very good disease control, then you can offer them vaginal delivery. There is no difference whether you go for a cesarean or a vaginal delivery. You can safely offer them vaginal delivery. On the other hand, if it is more than 450, definitely cesarean section. In between that, better to offer them cesarean section. So if a MCQ says, or if a question says, all HIV positive patients should undergo cesarean section for the delivery, true or false? It is false. It is false. If you are on multiple drugs and if your viral load is below 50, they can undergo vaginal delivery. You don't have to offer them cesarean section. Is that clear, Darwin? Is that clear? Any problem so far? Please clarify your doubts before we move on. Now, the teaching that what we had when we were students, right? So when we were students, we were told that all HIV patient, positive patients should undergo cesarean section for the delivery. But now it has changed. Okay. So if they are on pseudovidin monotherapy, yes. If they are on multiple drugs and the viral load is more than 450, yes, but not otherwise. If the viral load is below 50 and if they are on multiple drugs, then you can offer them vaginal delivery.
Sir?
What is the effect of HIV on the baby? No effect. But HIV can transmit it to the baby and baby can get the HIV infection. However, otherwise, during pregnancy, HIV will not cause any congenital abnormalities in the baby. Okay, Tarilu? Right. Any problems or other? So we have discussed two important infections. One is syphilis, other one is HIV. I hope you all understood. Vilangada. Good. Shall we move on to the next topic? That is hepatitis B. Hepatitis B. Okay. So we will discuss about hepatitis B. Hepatitis B. Hepatitis B also a viral infection. It's a viral infection. It's again a DNA virus. Hepatitis B is a DNA virus. Remember, those are MCQs. HIV is an RNA virus. Hepatitis B is a DNA virus. Okay. So when we are going to discuss about this hepatitis B, you have to have some basic understanding about the structure of this virus. Okay. So when you take this virus, Darwo, you have an outer shell and an inner core. Outer shell and an inner core. Okay. On this outer surface or this shell, you have a specific protein that is called hepatitis B surface antigen. Surface antigen. Hepatitis B surface antigen. You know, surface means it's outside. So in this viral molecule, if you take the viral molecule, it is on the outer layer. Okay, on the outer surface, there is a particular protein that is called surface antigen. Okay, what is the importance of this thing? This is the one, this is the antigen, this is the protein which causes all the complications in the host. This is the one which causes all troubles in the patient's surface antigen. So if someone having positive hepatitis B surface antigen means she or he is having the active disease. Remember. So how to diagnose hepatitis B viral infection? You have to see this hepatitis B surface antigen is there. When you are giving the hepatitis B vaccine also, when you are going abroad, you have to get the hepatitis B vaccination. What is the vaccine that you are giving? Again, this surface antigen in an inactivated form to inject. The same antigen you are giving, but in an inactivated form. Not a virulent form, but inactivated form, you give the surface antigen. So if you want to diagnose hepatitis B surface antigen, if you want to diagnose hepatitis B infection, you have to do hepatitis B surface antigen. So when the virus entered into your body, or particularly this antigen entered into your body, what does your body do? The body will produce antibodies against this. Antibodies against this. So if someone is having hepatitis B surface antibody for uncle body, antibody, surface antibody. What does that mean? You are immune for hepatitis B. You are not having the disease, but you are immune. Okay, so if someone is having the hepatitis B surface antigen means you are having the disease. You are having the active viruses in your blood, in your body fluids now. Okay, whereas if someone says you are having hepatitis B surface antibody positive, what does that mean? You have developed the immunity against the antigen. That means you are immune now. Either you got the infection before and recovered, or else you got the vaccine before and now you are having the antibodies. Okay. Okay, Jonathan. So in the exam, Davo, please read the question carefully. Whether they are going to talk about the hepatitis B surface antigen, that is the disease, or whether they are talking about the hepatitis B surface antibody. Antibody means you are immune. You don't have to be worried. Okay, Darwin, right? In addition to that surface antigen, Darwin, inside this core, you have another antigen that is called hepatitis B E antigen. E antigen. E antigen. So, in addition to hepatitis B surface antigen, if someone is having hepatitis B, E antigen also positive. E also positive. What does that mean? Priyanjay, what does that mean? If you have the E antigen also positive, what does that mean?
Active disease.
Yes, surface antigen means you have the active disease. In addition to that, E antigen also positive. Suppose you check my blood, my E antigen is positive. What does that mean? You are highly infectious. You are having the disease. Not only that, you can easily transmit this disease to another person. Highly infectious.
Okay.
Okay, right. So please remember that if hepatitis B just surface antigen is positive, means you are having the disease, you are having the active disease, you may transmit disease to another person. Possible. In addition to that, if you have E antigen also positive, that means you are highly infectious. You can transmit this disease to another person easily. Easily. That is the importance of that. But over the time, though, when you have these both antigens, they will develop antibodies. If hepatitis B E antibody is positive, what does that mean? E antibody positive, not the antigen, antibody positive. The ability to transmit this infection to another person is very low. If the antibody is there, your ability is less, but if the antigen is there, your ability is more. Got it? Any problem? Have I confused you all? It's very interesting to confuse students. Have I confused you all? Not yet. Okay, Darwin. So if someone is having hepatitis B surface antigen, you are having the active disease. If you have the surface antibody, you are cool. You have the immunity for hepatitis B. If you have surface antigen and E antigen both positive, you are a very dangerous person. You have your disease and you are capable of transmitting this infection to another person easily. Easily. How does a person can transmit hepatitis B to another person? Same as HIV. You know how the HIV is transmitted? By sexual contacts, by blood products. Okay, sharing this the needles and blades and all, drug abusers, right? So those are the ways where HIV can transmit from person to another person. Hepatitis B also the same. Okay, by the needle pricks, injuries, then sexual contact, homosexual or heterosexual contact. Okay, so same as HIV. Suppose I am having HIV. A mosquito comes and bite myself and go and bite you near Priyanjay. Will you get HIV now? The same.
No, sir.
Huh?
No.
By mosquito bites, you won't get HIV or hepatitis B, right? Fortunately, you can't transmit the infection in that way. Okay, so either it should be a needle prick injury or some these drug abusers or homo or heterosexual contacts. organ donation, organ transplant is a very risky procedure, right? The HIV and hepatitis B both can be transmitted in that way. Okay. If someone gets hepatitis B, what can happen to him? If someone gets hepatitis B, what can happen to him? What is the sequelae? What is the outcome of this infection in this person? Sorry. Yes, this is the hepatitis B viral particle. You can see the surface antigen there, right? So, right. So, if someone gets hepatitis B, majority of the cases, these are MCQs that only, majority of the cases, if someone gets hepatitis B, if you have a good immunity, you can get rid of this infection from your body. You can develop antibodies by yourself and you can remove the viruses from your body. So majority will recover. Majority will recover. Remember, majority will recover. More than 75% of people with hepatitis B will recover, provided that you have a good immunity. Okay, Daru? But minority, those immunity is low, what can happen to them? This hepatitis B surface antigen or these active viral particles can be there more than 6 months in their blood. When this virus is there more than 6 months, they will convert into what is called a chronic carrier state. They can go into chronic carrier state. If the virus survives more than 6 months in the bloodstream. Chronic carrier state. When a person going into chronic carrier state, what can happen? It can cause, it mainly affect the liver, so it can cause chronic hepatitis, it can lead to cirrhosis, and over the time, it can lead to hepatocellular carcinoma. So chronic hepatitis, cirrhosis, and hepatocellular carcinoma. This is the problem in hepatitis B. Okay. Hepatitis B people can go into chronic carrier state and develop these complications like chronic hepatitis, cirrhosis, or hepatocellular carcinoma. Hepatocellular carcinoma, sorry. Hepatocellular carcinoma. Okay. So, is there a treatment like hard therapy for HIV? Is there a drug treatment for hepatitis B? Is there a drug treatment for hepatitis B? Now, yes. Those days, no. Now there are antiviral agents available for hepatitis B. One of the agents is called tenofovir. 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 Most of these antiviral agents start with vir, like acyclovir, ganciclovir, like the same way here, tenofovir. Tenofovir is one of the agents that can be used in hepatitis B infection. So there is a drug treatment also. So if a mother having hepatitis B, what is the problem to the baby? This mother can easily transmit this infection to the baby, or it's called vertical transmission again. From mother to child transmission can happen with hepatitis B. But not like in HIV, hepatitis B is not an indication for cesarean section for the delivery. Hepatitis B not a definitive indication for cesarean section, not like HIV. If a mother is having hepatitis B surface antigen positive, surface antigen positive, what you have to do after delivery, baby should be given passive immunization. Not passive, sorry, active immunization. Baby should be given active immunization soon after the delivery. Baby should be given active immunization. If the mother is having E antigen also positive, you have to give active plus passive immunization for hepatitis B. That means immunoglobulins and the vaccine both should be given to the baby. If a mother is having hepatitis B surface antigen positive, at the time of delivery, baby should be given the active immunization vaccine. If the mother is having E antigen also positive, you know, if the E antigen is positive, she is highly infectious. So baby should be given active plus passive immunization both soon after delivery. Soon after delivery. Any problem so far? Any problem? So far we have discussed about syphilis, HIV, hepatitis B. Any problems you all have? These are hot areas for your MCQs. Okay, right? Shall we take 30 seconds off? Don't go out, just stay here. Just take 30 seconds off. Take your time to send a message to your boyfriend or the girlfriend. Something like that. If anything not clear, please let me know that. Yes.
If hepatitis B E antibodies are positive, patient's ability to transmit the disease to another is high or low?
If E antibody is positive,
Yes.
the chance is very low.
Okay, sir. Thank you.
E antigen is positive, highly infectious.
Okay, sir. Thank you.
Any other questions, Dharma? Any problems so far? Okay. Shall we move on to the next topic? Right. Now, next will be herpes. Herpes. So, compared to HIV, hepatitis B, and syphilis, herpes is one of the common viral infection. Okay, it's one of the commonest viral infection compared to the rest of the infections that we have already discussed. Herpes will be caused by a virus, which is a DNA virus. Again, it will be a DNA virus. Herpes, there is herpes simplex virus, HSV. There are two types, herpes simplex 1 and herpes simplex 2. Normally, herpes simplex 1 causes oral ulcers. Simplex 1, herpes type 1, causes oral ulcers like this way, around the mouth. You get the lesion, blister formation, and they will crust, okay? And you will get this kind of lesions around the mouth, herpes simplex 1. Herpes simplex 2 will cause genital ulcers. Genital ulcers. But sometimes herpes simplex 1 can cause genital ulcers, herpes simplex 2 can cause oral ulcers. Don't know the reason. You guys have to find it out later once you become doctors. Why herpes simplex 1 causes genital ulcers? No explanation, no comments, right? So remember, normally HSV 1 causes oral ulcers, 2 causes genital ulcers, but it can change. Now, when it comes to these ulcers, Taruni, herpetic ulcers, now initially we get a blister formation. You can see on this vulva, right? There are lots of blisters everywhere, and ultimately they will rupture and causes multiple painful ulcers. Herpes causes multiple painful ulcers compared to what you had with syphilis. Though it's a single painless ulcer, but here multiple painful ulcers. So herpes causes multiple painful ulcers. Multiple painful ulcers. That is the characteristic feature of herpes. And Darwin, these herpetic ulcers are extremely painful. Extremely painful. So what will happen? Because of the pain, most of the people will be presenting with acute retention of urine. Because of the pain involving the vulval region, it causes severe pain. So patient can't go to the toilet and pass urine. So herpes causes multiple painful ulcer formations, which typically causes acute retention of urine. So in your exam, if they talk about acute retention of urine, one of the differential diagnosis would be herpes. Just give me 1 second, Daruni. Okay, Darwani, right? So it causes severe painful ulcers, which can cause acute retention of urine. Now, another complication of herpes is this herpes can be transmitted to the baby during pregnancy. So normally herpes is transmitted to the baby during the birth passage. When you're going for vaginal delivery, during the birth passage, this infection can transmit to the baby. When it goes to the baby, it can cause severe infection in the baby. Baby can get severe meningoencephalitis. Right, like this way, the newborn baby can get severe meningoencephalitis, usually fatal. Baby can die, or baby can get cerebral palsy. Anything possible. Anything possible. Okay, Daru, right? So this is the problem with this herpes simplex viral infection. So the main problem now, when it comes to herpes simplex virus, actually the clinical picture, you can get what is called primary herpes simplex virus or secondary HSV infection. Primary herpes, secondary herpes. Okay. So what is the difference between primary herpes and secondary herpes? Kinkini, what is the difference between primary herpes and secondary herpes? What do you mean by primary and what do you mean by secondary? Primary herpes viral infection means that only for the first time, if someone gets the clinical features of herpes, that is called primary herpes. So when someone gets this primary herpes infection, with your immunity, it will subside. However, these viruses are so cunning, they can go and hide within the spinal ganglions. Within the nerve roots, they can hide. And they can reactivate later. Then, when a person gets repeated manifestations of herpes, that is called secondary herpes. Primary herpes means for the first time. Secondary herpes means recurrent infections. Herpes. Which one is more dangerous? Is it primary or the secondary? Which one is more dangerous? Primary herpes or secondary herpes? Primary herpes, Udari, primary herpes is more dangerous than secondary herpes. Why? When mother is having primary herpes, there is about 30% chance the baby can get the infection. 30% chance, 1/3 of cases. Whereas recurrent herpes, just 3%. Chance the baby can get the infection is about 3%. So primary herpes, it is 30%, high chance. And the symptoms also are worse, more severe with primary. Primary herpes causes severe infection, severe lesions, whereas recurrent herpes is not that severe. So when it comes to the delivery, listen. If a mother is having primary herpes, remember this is a very common exam area, right? If a mother is having primary herpes with active ulcers and all, at the time of delivery or after 36 weeks, you have to offer them elective cesarean section. Primary herpes simplex virus in pregnancy, usually you have to offer them elective cesarean section. Primary herpes better delivered by elective cesarean section. Recurrent herpes, a person who had infection before, had several episodes before, now during this pregnancy also she's having recurrent episodes. How will you deliver? Tarindu, how will you deliver recurrent herpes? It is not a definitive indication for cesarean section, even they can undergo vaginal delivery because mother-to-child transmission is about 3%. So recurrent herpes, or the secondary herpes, or the recurrent herpes, elective cesarean section is not indicated. Elective cesarean section is not indicated. Okay, so please remember, herpes, it can cause oral lesions, it can cause vulval lesions or genital lesions, right? Characteristic, it causes multiple painful ulcerations. So typically, patient will be presenting with severe vulval pain and acute irritation of urine. It's a clinical diagnosis. When you look at the lesions, you can diagnose clinically herpes simplex viral infection. There are two types. You can get primary herpes or recurrent or secondary herpes. Primary herpes is more severe. Usually, if that happened during pregnancy, after 36 weeks, usually they offer them cesarean section for the delivery. But recurrent herpes, not an indication for cesarean section. What is the treatment for herpes, Daru? Again, it is Acyclovir. Acyclovir. Acyclovir, that is the same drug that you give in chickenpox also. Acyclovir is the treatment of choice. And there is another funny thing that you can do in these patients, that is called sitz bath. Sitz bath. Sitz bath. Sitz bath. BATH. What is this sitz bath? Okay, so this is a patient. You take a bucket of slightly warm water and dissolve handful of salt and ask the patient to remove the clothes and ask her to sit on this water and wait for about 20 to 30 minutes. So you remove your dresses, right? Or go to a washroom, right? And sit on this salt water for about 20 to 30 minutes. That is really helpful to heal these ulcers. This is called sitz bath. Sitz bath. Okay, main treatment is acyclovir. Any problem so far? We can go up to 5, isn't it? Okay, so you don't have classes till 5 as far as I'm aware. If I'm not correct, please let me know that. Okay, so shall we take 5 minutes break now before we move on to the next topic? So take 5 minutes break, right? And come back in 5 minutes. Exactly in 5 minutes. Yes.
So what's the purpose of doing it? I mean,
Sitz bath, you mean?
yes, sir.
Yes. The exact purpose we don't know, but it says like, salt water is highly concentrated water. So that may kill the virus in one way, and that will be helpful for the healing process of these ulcers. So in addition to acyclovir, if you do the sitz bath, it really shortens the duration of the illness, and the symptoms can be minimized. Okay. So have 5 minutes break and please rejoin. Okay, shall we restart, Daruni? Okay, after this short break, because it's a small class, so I can't give you a long break, right? Okay, right. So any problems so far? No, right. So now we'll be discussing chickenpox in pregnancy. Okay, that is again one of the important infection, and it's a very common infection in Sri Lanka, right? So you should know everything about chickenpox in pregnancy. So again, chickenpox is a viral infection caused by varicella zoster. Okay, the organism, the virus is varicella zoster. Is it a DNA or a RNA virus? Again, a DNA virus. Right? Like hepatitis B, this is also a DNA virus, varicella zoster. So the incubation period. What is incubation period, Darwin? Anyone knows about incubation period? What is incubation period? Incubation period means, suppose now when you get an infection, when the virus or a bacteria or somebody entered into your body, on the same day or soon after entering into your body, they can't make manifestations. They will not do clinical symptoms and signs. It will take some time. Say, for example, if you take even corona, highly infectious, but still, once you get the virus into your body, on the first day, they won't show clinical features. At least it will take 3 to 4 days. So like the same way, Daru, any infection has what is called incubation period. After entering into your body, till you develop the symptoms, that's called incubation period. So incubation period for this chickenpox is, cuckoo-pox is about 2 to 3 weeks. 2 to 3 weeks. It is the same as rubella. Rubella also 2 to 3 weeks. Chickenpox also 2 to 3 weeks. So when it comes to chickenpox, what are the effects of chickenpox to the mother and to the baby? When it comes to the maternal effects of chickenpox, what do they can cause to the mother and what are the effects to the baby? Mother, baby. As far as the mother is concerned, this is usually a self-limiting infection. That means once you get it, because of your immunity, you can clear off the infection. That is called self-limiting. Okay? However, especially during pregnancy, about 15%, about 15% of patients can go into a complication called chickenpox pneumonia. Like COVID pneumonia, people are dying because of COVID pneumonia, not COVID infection. Because of COVID pneumonia, people are dying. Chickenpox also can cause chickenpox pneumonia in about 15% of people who got the infection. So, if someone gets this chickenpox pneumonia, there's a high chance of death. It's a serious complication. It's not common, but can get. So that is the main complication, but rarely, again, they can get meningoencephalitis also. Meningoencephalitis also, sometimes they can get. Okay, meningoencephalitis, sorry. You can get meningoencephalitis. But those complications are not common though. As far as the baby is concerned, what are the effects on the baby when you have chickenpox? If a mother develops chickenpox within the first 20 weeks, of pregnancy, after 20 weeks, what can happen to the baby? This infection can transmit it to the baby, and baby can get a lot of anomalies. That is called fetal varicella syndrome. Fetal varicella syndrome. fetal varicella syndrome. That may happen or that may occur up to about 20 weeks. What are the features of fetal varicella syndrome? Microcephaly, head small. They can get cataract. Small kids, newborn kids can get cataract. Microcephaly, when there's microcephaly, small head, definitely they are mentally retarded. Microcephaly, cataract, and they can get limb hypoplasia. Okay, about few years ago, about 10 years ago, when we were students in Peradeniya, there was a person, right, near the bus stand with limb hypoplasia. That is typical of fetal varicella syndrome. And the other thing is, they will get intensive skin scarring, like a map on the body, skin scarring. Okay, those are the characteristic features of fetal varicella syndrome. What are the characteristic features, Darwa? They can get limb hypoplasia and skin scarring. In addition to that, they can get microcephaly and cataract as well. Fetal varicella syndrome. Sorry, I have to do babysitting also today. I'm really sorry of the disturbance, right? So, fetal varicella syndrome, those are the two characteristic features that are in skin scarring and limb hypoplasia. If I show you this picture, yes, this one. Yes, you can see the extensive scarring of the skin, this characteristic, as well as limbs are small, limb hypoplasia. This is a characteristic feature of fetal varicella syndrome. That can happen up to about 20 weeks in pregnancy. Up to about 20 weeks. Okay, right? That is one thing. That is one effect to the baby. Now, if someone gets chickenpox closer to delivery, or at the time of delivery, closer to delivery, by that time, all the organs, limbs, skin, and everything is now well developed. So they won't get these abnormalities. Instead of that, they can get what's called congenital varicella or neonatal varicella. Neonatal varicella syndrome, where baby can get severe meningoencephalitis. 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 Okay, so as far as the chickenpox is concerned, it is caused by a virus, varicella zoster virus. Incubation period is about 2 to 3 weeks. For the mother, rarely, about 50% of cases, mother can get varicella pneumonia. That is very serious complication. And when the baby is concerned, up to about 20 weeks, Darwani, you can get what's called fetal varicella syndrome. Fetal varicella syndrome. In fetal varicella syndrome, all these abnormalities, skin scarring, limb hypoplasia, microcephaly, all these clinical features you can get. Whereas, if the mother develops the infection closer to delivery, in that case, you won't see these malformations. Instead of that, you will see meningoencephalitis. Baby will get meningitis and encephalitis, meningoencephalitis. If a mother develops chickenpox in pregnancy after 20 weeks, up to about 32-34 weeks, what can happen to the baby? Up to 20 weeks, fetal varicella syndrome. After about 32 weeks, that is closer to delivery, neonatal varicella. In between that, after 20 weeks, up to 32 weeks, if a mother develops chickenpox, what can happen to the baby? Suppose now your neighbors, your friends and relatives, everybody think that you all are now doctors, and they will come behind you for medical advices. Russia, Ukraine, now they will come and ask from you all, suppose there's a teacher, one of my school children, children in my class got chicken pox. Now I am pregnant, I am now 28 weeks. What will happen to my baby now? Anyone? What is the effect on baby after 20 weeks, up to 30 weeks?
Nothing will happen, sir.
No effect, no fetal effect. So that is a safe window period for the baby. So the problem comes if the infection occurs within the first 20 weeks or after 32 weeks. In between that, there are no effects to the baby. Safe. What is the treatment for chickenpox? In our Gamegode area, people used to take this infection as Deyangelida. Deyo tamai karanga. Basically, Deyo somebody comes and do the problems, right? Deyangelida, and people were not allowed to eat any, meat, fish, nothing, just the vegetarian diet. But we know this is not because of the Deya, this is because of the virus. So they need to have a good nutritious diet during this time period, and the drug of choice is acyclovir. Acyclovir. Same drug that you have given in herpes infection. Okay, here also herpes in chickenpox also you have to give acyclovir. Okay, acyclovir. Suppose there is a pregnant lady, please say, teacher, she's pregnant, she's now 10 weeks of pregnancy. She never had chickenpox before, so she's not immune for chickenpox. A person who never had chickenpox before, now she's pregnant, early pregnancy, had a significant exposure to chickenpox. Significant exposure to chickenpox. And she's now worried, what are the things that you can do to prevent she's getting the infection now? You got my scenario. The scenario is she's a teacher having a close contact with a chickenpox kid in this classroom. She's now pregnant and 10 weeks, never had chickenpox before. So potentially she is having a high risk of getting chickenpox now. So how you can minimize this risk? How? For the preventive purpose, you can give varicella zoster immunoglobulins. Varicella zoster immunoglobulin. Varicella zoster immunoglobulins. So people who had exposure to chickenpox and who is non-immune for chickenpox, to prevent chickenpox, you can give varicella zoster immunoglobulins. Remember, Daruane, this is for a preventive purpose. This is not a treatment, but for the prevention of chickenpox. Okay, so this is for the prevention of chickenpox. You can give varicella zoster immunoglobulins. Okay, clear, right? And there is a vaccine also for the primary prevention of chickenpox. There's a vaccine, but the problem with chickenpox vaccine is during pregnancy you can't give because it's a live attenuated vaccine. You all know that live attenuated vaccines are not given usually during pregnancy. So we don't give the vaccine during pregnancy. However, if there is a significant exposure, you can give SOS immunoglobulins. Softer immunoglobulins. And soft immunoglobulins. Right? Now, when you come to chickenpox, this is the central nervous system. This is the spinal cord. You have spinal ganglions like this, spinal nerve roots, spinal ganglions, right? Like this way. So, when you get a chickenpox infection, Daro, with your immunity, if you have good immunity, usually it is self-limiting. You can control the disease. Okay? So when your immunity develops, what happens is some of the viruses, they're so funny, they will go and hide behind these basal ganglions. They hide there. And they become dormant. Dormant means they are not active. They're just there. Right? Like our ministers these days, they are not active, they are just there spending all our money. So this virus is also the same. When your immunity develops, they go and hide behind this ganglion and stay there even for years and years, even till you die. And now the person is doing his routine things with good immunity. As long as your immunity is good, they can't reactivate. However, due to some reason, if your immunity drops, like if you have diabetes, if you have HIV, or if you have some immunosuppressive drug or something, if your immunity drops, what happens is these viruses now laughing like that, they will reactivate and they can cause symptoms again. What symptoms are they? They will not cause generalized symptoms like chickenpox, not like generalized symptoms like chickenpox. However, they will cause lesions, maculopapular blistering lesions along the particular dermatomes. Suppose if the viruses here are activated, they will cause lesions along that dermatome. You all know what is a dermatome, right? Like this umbilical T10. If you get the T10 activation, you will get the lesions along this dermatome, like this way. What is this condition called? Herpes zoster or zoster. Okay, zoster, herpes zoster or zoster. So, whether you have chickenpox or herpes zoster, it is both are caused by the same organism. Chickenpox causes generalized lesions, whereas herpes zoster causes localized or along a dermatome. So you can see in this patient, along this dermatome, you have the lesions. But the rest of the body looks normal. This is called herpes zoster. Sorry, zoster. Yes, basically zoster. Now suppose a person who is having zoster now, she's having zoster along this dermatome. There is another person who never had chickenpox and having a contact with this person. Now everybody take a deep breath, leave everything aside, right? Think leisurely. Now I'm going to discuss about a different thing. Now this lady initially had chickenpox, she recovered, and later due to some reason, these lesions reactivated and she got now zoster. You can see along this dermatome, she's having zoster. Now suppose she's having a contact with another person who never had chickenpox before. So what can happen to that person now because of the contact with this lady? The zoster will not cause a zoster in the next person, will cause us chickenpox in the next person. When she has a contact with these lesions, the next person, third person can get chickenpox, not the zoster. So zoster you will get only in a person who initially had chickenpox. Because this is because of the reactivation of the viruses in the basal ganglia. Okay, Daru, is that clear? So chickenpox is caused by varicella zoster virus. It's a DNA virus. Incubation period is 2 to 3 weeks. They causes macular-papular rash. Like this way, it's a generalized rash all over the body. You will get this macular, papular, and blistering rash. There are blister formations and blisters will blast, right? Rupture like that, and there's the crust formation. So this is typical chickenpox rash all over the body. So treatment is acyclovir. Treatment is acyclovir. If you want to prevent the infection occurring, you have to use soft immunoglobulins. As far as the pregnancy is concerned, mother can get varicella pneumonia, that is serious, and baby can get within the first 20 weeks fetal varicella syndrome. This is that fetal varicella syndrome. Can you all see these pictures, Tarvani? Can you all see these pictures what I am showing you all, right, on the screen?
Yes, sir.
Okay, thank you, Daru. Right? So this is fetal varicella syndrome, or else in the latter part of pregnancy, if the mother gets chickenpox, baby can get neonatal varicella, that is meningoencephalitis, serious again. What I told you all, when someone is recovering from chickenpox, some of the varicella viruses will go and hide behind this basal ganglion, and later they can reactivate. If there's a reactivation, they cause a zoster. They cause a zoster, herpes zoster. So, if a person who has a zoster get in contact with another non-immune person, that person will get chickenpox, not the zoster. Because zoster is because of a reactivation of the virus. For that matter, you need to have the virus in advance. Okay, Darwani, is that clear? Yes. Now suppose if a mother who is non-immune for chickenpox, now she is pregnant at 12 weeks, she developed chickenpox. So potentially there is a chance the baby can get this fetal varicella syndrome. What you can do? What you can do? Can you terminate the pregnancy? Can you abort the pregnancy because of chickenpox? No. Termination is not allowed. You have to continue the pregnancy. In Sri Lankan setup, termination is not allowed for that purpose. You can't do anything. Suppose a mother who is now closer to delivery, suppose she is 39 weeks, developed chickenpox. She is now closer to delivery. She is about to deliver now. Now she developed chickenpox. What is the risk to the baby, Lakshmi? What is the risk to the baby, Daru? The baby neonatal varicella syndrome. Very good. The baby can get neonatal varicella syndrome, meningoencephalitis, and serious complications. So, what is the management? Definitely, when chickenpox develops, you have to start acyclovir. Okay. And if she's closer to delivery, Dargo, you should give a try to postpone the delivery at least for 1 week. So if she is closer to delivery, you have to postpone the delivery at least for 1 week. Say for example, she's waiting for induction of labor at 39 weeks or 40 weeks. In that case, you don't do the induction at 39 weeks, you wait till 40 weeks or 41 weeks for the induction. So likewise, you postpone the delivery. What is the purpose of postponing the delivery? So now suppose mother is 39 weeks, having chicken pox now, 39 weeks, having chicken pox now, what you have to do? You start a cyclovir, you postpone the delivery for 1 week. What is the purpose of postponing the delivery? Rather deliver it now to wait for 1 more week to deliver this baby. Can someone give a try? Why is that? What may be the reason?
Because mom will produce antibody.
Yes. If you wait for 1 week, Dargo, the mother will produce antibodies. And these antibodies will cross the placenta and go to the baby. And baby also will get the antibodies. So baby is protected. So that's why if a mother develops chickenpox closer to delivery, you don't deliver the baby right now, you wait for 1 more week. By waiting, you allow the mother to develop antibodies, and those antibodies can cross the placenta and go to the baby, and now the baby is having the antibodies with them, so the complications to the baby will be minimal. Okay, Iran. So she is now 39 weeks, came for the delivery, developed chickenpox. You don't deliver her now, you wait for 1 more week, giving acyclovir. Suppose now she's in the ward. After about 2 days, she has gone into spontaneous labor. She went into spontaneous labor. You wanted to postpone it, but mother spontaneously went into labor. What you can do now? What you can do now? Now, your plan was to deliver her on next week. However, on the following day, she went into spontaneous labor. So when someone has gone into labor, that is very difficult to suppress the labor. No one can do it. Even with poor politics, it's very difficult to stop the labor if it is advanced. No one can reverse it. So, if the mother having lesions delivers within 1 week after the onset of lesions, if she is delivered within 1 week, what can I do? After delivery, baby should be given varicella zoster immunoglobulins soon after delivery. Okay, so please remember about these scenarios. Please try to understand them. Okay, so if a mother develops, I'm talking about chickenpox in later pregnancy. If someone having chickenpox, don't deliver them now. You wait for 1 week for the antibodies to produce, and after that you can deliver. However, if they go into delivery before 1 week, what you have to do is soon after delivery, baby should be given varicella zoster immunoglobulins. Is that scenario clear, Darwani? Are you all confused now? Not yet. Now I'm going to confuse you all further. Now suppose this is a pregnant lady, the party body, pregnant lady came to the ward and just delivered at say 40 weeks. 40 weeks she delivered. On the following day, when you do the ward rounds, you will see she's unwell. She's running fever and there are blisters appearing on the body. But just by looking at it, you can say this is chickenpox. Suppose a previously healthy lady delivered and within 7 days of delivery, she is having now chickenpox. What will you do now? What will you do now? Is the baby at risk of neonatal varicella? Yes. Why? Why? Even though she is now delivered, now having the symptoms, she would have acquired that infection about 2 to 3 weeks ago, while the baby was inside. So probably that infection would have gone into the baby also now. Baby also having the infection now. Viruses now. Because even though she is now developing the symptoms now, this infection, these viruses would have entered about 3 weeks ago. Incubation period 3 weeks. So by that time, baby was inside. So definitely this virus is now there in the baby as well. So what we will do there? Again, soon after the diagnosis, the baby should be given varicella zoster immunoglobulins. There are 3 scenarios I discussed. Chickenpox in latter part of pregnancy, towards closer to delivery. First thing, postpone delivery for 1 week, give acyclovir. That is the management. If the baby is delivering after 1 week, no problem for the baby. Second scenario, you wanted to wait for 1 more week, however, patient went into labor within that week. What you have to do? Soon after delivery, baby should be given zoster immunoglobulins. Third scenario. Previously asymptomatic patient went into delivery. After delivery, within 7 days of delivery, she developed chickenpox. What should be done to the baby? Again, baby should be given acyclovir. Is that clear or not clear? Umeshan, Vilangada, is that clear?
Yes, sir.
Great. Okay, so don't confuse with this. You know, understand clearly these scenarios. There are 3 scenarios actually. On the other hand, somebody asked, what is the treatment if someone develops chickenpox within the first 20 weeks? What you have to do? If someone develops chickenpox within the first 20 weeks, you have to start acyclovir, that's all. Acyclovir up to 20 weeks is cautious. After 20 weeks, you can give freely, but up to 20 weeks, it's called cautious. Most of the drugs during pregnancy are cautious. Means not 100% safe, not 100% bad also. Cautious. But still, you need to consider. And Darwani, when you are giving acyclovir, it should be started soon as possible. When you see 1 or 2 blisters, you have to start acyclovir. No point of starting acyclovir when there's generalized rash everywhere. So, I mean, purpose of acyclovir is not there. So you have to start soon as possible in very early disease. Okay, now tell me, everyone, how you can prevent acyclovir? Sorry, how you can prevent chickenpox? By 2 means. One is varicella zoster immunoglobulin. Second thing is vaccination. But vaccination you can't give during pregnancy because it's a live attenuated vaccine. What are the fetal complications during the first 20 weeks? Fetal varicella syndrome. What are the fetal complications towards the delivery, closer to delivery? Neonatal varicella syndrome. Okay, and how you tackle these patients is different. Is breastfeeding avoided after delivery if mother is infected? Usually not. Usually breastfeeding is not contraindicated when the mother is having chickenpox. Because you want to know, breastfeeding has lots of antibodies and protective mechanisms to protect the baby. So you don't avoid breastfeeding just because chickenpox. Okay, Dharwani. Any problems so far? Anything just not clear or confusing? Shall we discuss about rubella infection in pregnancy, rubella? Okay. Rubella. Rubella also a viral infection. Viral infection. It is caused by a RNA virus. Remember, RNA virus. What are the RNA viruses so far, Daru? HIV and rubella. HIV and rubella are RNA viruses, and the rest of the viruses we discussed so far are DNA viruses. Okay, please remember. So this is also the RNA virus. When it comes to the incubation period, it's same like chickenpox, 2 to 3 weeks. Rubella, 2 to 3 weeks incubation period. As far as the mother is concerned, this is just a viral infection. So no effects to the mother. Extremely rarely they can get meningoencephalitis, but usually rubella will cause just fever and a skin rash in the mother. Fever and skin rash. This is in a non-pregnant state. It won't cause none of the problems, but in pregnancy you can get this fever, skin rash, and post-auricular lymphadenopathy. What is post-auricular lymphadenopathy, Daru? Now behind the ear, you will get lymph nodes enlarged. Post-auricular lymph nodes, typically with rubella. What are the fetal effects of rubella? If a mother is having rubella during the first trimester, lots of complications can happen to the baby. Anomalies, microcephaly, mental retardation, eye defects like cataract, ear defects. Everybody have a look. It's all given in your handout. Eye defects, ear defects, heart defects. So it's like a triangle. Cataract, eye defects, sensorineural hearing defects, ear defects, and then cardiac defects. So this triangle is called Gregg's triangle. Gregg's triangle. So lots of anomalies you will see with this infection to the baby. Lots of anomalies. Because of that, in other countries like North America or UK, right? If someone having this rubella infection during the first trimester, confirmed rubella in first trimester, it's an indication for termination of pregnancy. So they are like, doctor, I don't need this baby. I need to go for a termination. But you have to accept that thing, that request, and you have to offer them termination of pregnancy because it's so serious. But in Sri Lanka, there is no legal background for you to do termination for fetal reasons. So in your SBS, right, in Sri Lankan setup, it's not, you can't offer termination for rubella. But if my baby is having rubella, all these complications can get anomalous baby. Anomalous baby. Is there a treatment for rubella? No treatment. No treatment for rubella. Okay, can you prevent rubella? Yes, there's a rubella vaccine. A Again, a live attenuated vaccine is included in our EPI program, extended program of immunization, EPI program. In our schedule, rubella also included. So by vaccination, you can prevent it. But once you get the disease, there is no treatment. Again, during pregnancy, you can't use rubella vaccine because it's a live vaccine. Suppose, Tarwani, a newly married, lovely couple come to your clinic. Now they come to your clinic and tell, doctor, we are recently married, we are planning a pregnancy, we want to have a baby. So when you inquire from them, the girl says, lady says, I haven't got my rubella vaccine when I was a child or school time. I couldn't get my rubella vaccine. So now what you can do? She is not immune for rubella. So the recommendation is anyone who is not immune for rubella, you have to get your rubella vaccination before pregnancy. Before pregnancy. Okay, Milangi, before pregnancy, you have to get your vaccine. Once you become pregnant, you can't get your vaccine before pregnancy. And after pregnancy, she will ask, doctor, how long do I have to wait for a baby? Now today I got my rubella vaccine. How long do I have to wait? How long? You have to keep the husband outside for 1 month. Are you outside here? We don't know. Avoid pregnancy at least for 1 month after the vaccination. Better if you can wait for 3 months. Husband, even just 1 month is enough prior to pregnancy. Okay, Tarushi. Suppose there's a patient comes and tell you, doctor, I got my rubella vaccine, doctor, but I didn't know that I was pregnant. Now she's already pregnant without knowing she got her rubella vaccine. After getting the vaccine, she came to know that she's pregnant and she's now 12 weeks. What will you do? You got my question, Daru. Now, patient was not immune for rubella before, so she got the vaccine thinking that she's not pregnant. However, by the time she got the vaccine, she's already pregnant, say 12 weeks. What can happen to the baby? Can the virus causes rubella in the fetus? Theoretically, yes, sir. However, that chance is very, very, very low. Theoretically, that because of the vaccine, there's a chance that the mother can get rubella and that can damage the baby, but that chance is extremely low. So what you have to do, you have to just reassure the patient and send her home. Tell her that the chance that your baby is getting the rubella is extremely low, so don't worry. Go home, eat and drink and dance. Reassurance. Is that clear, Daruni? Okay. So please remember, if someone is not immune for rubella, they have to get the vaccine before pregnancy. And they have to wait for at least 1 month to conceive. But accidentally, if someone gets the vaccine during pregnancy, you can't do anything. Just reassure the patient saying that the chance of complications are very extremely low. So don't worry. Something like that. How will you diagnose rubella, Daru? For the diagnosis of rubella, you can use rubella-specific IgM antibodies. IgM antibodies. Do you know the differences between IgM and IgG? IgG, it's like this, Taruni. When you get an infection, initially, you will get IgM antibodies. This is IgM. Okay? It is an acute response of your body. Whereas, when you develop immunity later, gradually, a strong immunity, that is IgG, that will develop slowly and it will be long lasting. This is IgG. So, if someone is having positive IgM, that means she is having the active disease. Whereas IgG means she is immune. Having IgG antibodies means she had the problem before and she has now developed antibodies. Having IgM means she's running the infection now. So to diagnose rubella, you have to do rubella specific IgM. IgM. Any problems so far, Arun? Sorry. Any problems? Netra, any problem? No. Udari, any problem, Daru, so far? No. Good. Milangi, any problem? Right. So we have discussed lots of infections, right? I know that most of you can't remember all these stuff now, but when you have a free time, right, within 2-3 days time, please read this note again. Then these things will be registered in your brain, and you have to repeated reading and studying to register these things in your brain. So before I forget, I'm going to start the theory course. It mainly will be in the system, that is in the study reserve, right? Restreaming. So you can cover that thing with the restreams, and then we will do the questions, live questions discussions after the theory sessions. Okay. So because you have a limited time for your exam, some say that it will be on May, but we are not sure. So you have to cover your theory part soon as possible if you want to go into the question discussions, paper classes later. So you have to revise your theory knowledge. So it will be, those lectures will be available in a study reserve. So those who wish to join, you can join and join with those classes. Okay, Taruni? Right. So rubella, this is the business about rubella. Any problem? So rubella can cause problem to the baby. Chickenpox can cause problem to the baby. Herpes can cause problem to the baby. Syphilis can cause problem to the baby. Right. Now come to Power B19 infection. Power B19. Okay. Power B19 is kind of an interesting viral infection. Power B19. This Power B19 causes a characteristic clinical feature that is called slap cheek fever. So if you see this picture, you can see when someone slaps on your cheek, you will get the redness and this, edematous appearance on your cheeks. Right? You will get the same clinical picture, right? Slap cheek. So on either side, you can see these slap cheeks. So this is typical you can get with Power B19 infection. So in a non-pregnant state, though, this will not cause any significant problem to the patient. This is just a self-limiting viral infection. But in pregnancy, what can happen? This is also a DNA virus. In pregnancy, what can happen? This PAHO-B19 virus, a tiny viral particle, can cross the placenta and go to the baby. When they go to the baby, what do? This PAHO-B19, what is the effect on the baby? They go and act on, or they go and suppress the bone marrow cells in the fetus. So they will suppress the bone marrow of the fetus. So the fetal bone marrow will be suppressed by the virus PAHO-B19. So Dharwani, when the bone marrow is suppressed, what will happen to the hemoglobin production, red cell production? What will happen to the red cell production, Daru? Shinwa, what will happen to the red cell production? Amandi, what will happen to the red cell production? Red cell production will be suppressed because you all know the red cells or the hemoglobin is produced in the bone marrow. So when the bone marrow is suppressed, Darwani, Hiruka, when the bone marrow is suppressed, there is no red cell production. So basically, baby will be anemic. So initially, baby will be mildly anemic, then moderately anemic. Then if the damage is severe, baby will be severely anemic. Okay, Navati, Mashi, Metni. So baby will be severely anemic. When there is severe anemia, forget about the baby, forget about pregnancy. If someone is severely anemic, what can happen to them? What will happen to them if someone becomes severely anemic? Sorry, what will happen to them? If someone is severely anemic, what will happen to them? Kinkini, what will happen to them if someone is severely anemic?
Edema.
It can predispose to heart failure. Okay, when someone is anemic, the next thing is they can go into heart failure. When there is heart failure, what will happen to the fluids? You will get edematous extremities, edematous person. So same thing can happen to the baby. When the baby is anemic, baby will be having heart failure and edema. This is called hydrops fetalis. So baby can get what is called non-immune hydrops fetalis. Non-immune hydrops fetalis. There is immune hydrops fetalis also. I will discuss with you later in Rh negative mothers. Same thing happen in a different way. This is called non-immune hydrops. Non-immune hydrops. So there is a common MCQ saying that PAHO-B19 is a teratogenic virus. What do I mean by teratogenic virus? Teratogenicity. Teratogenic means it causes abnormalities of the baby, like limb hypoplasia, microcephaly, cataract, heart problems, and all this. Do they cause any of these things? No. PAHO-B19 is not a teratogenic virus. What they do is they suppress the bone marrow and cause severe anemia. So this is not a teratogenic virus. Remember, this is not a teratogenic virus. Unfortunately, there is no specific treatment for this condition. Only thing is, if you detect them, you have to consider blood transfusion to the baby. When the baby is inside, you can do what is called intrauterine blood transfusion, or you can deliver the baby and give extrauterine blood transfusion. What is intrauterine blood transfusion, Daru? When the baby is inside, you can give the blood transfusion. From the outside, you can give blood transfusion to the baby. Possible. Not easy, but possible. That is the management for PAHO-B19.
Sir?
Yes, sir.
So how it is done? I mean,
Other?
blood transfusion.
Yes.
How is it done?
Yeah, there are two ways, Taro. If the baby is extremely preterm, like say, suppose 28 weeks, 30 weeks, like baby is still premature and baby is inside. So under ultrasound guidance, you can puncture one of the fetal vessels, umbilical artery here, and you can give transfusion externally. That is called intrauterine transfusion. While the baby is inside, you can give the transfusion. Or else, if the baby is closer to 34, 35 weeks, what you can do is deliver the baby and give blood transfusion. That is called extrauterine transfusion. Is that clear, Daru?
Yes, sir. Thank you.
All right. Any other questions? Okay, right. Then come to this chlamydia and gonorrhea. First, chlamydia. Lukuaya is chlamydia. Kodinangi is gonorrhea. So chlamydia is the commonest sexually transmitted bacterial infection. Commonest sexually transmitted bacterial infection is chlamydia. They preferably infect endocervical epithelium. What is endocervical epithelium? This is the uterus. This is the cervix. And here you have the endocervix. This is called endocervix. This is called ectocervix. This is called endocervix. This is called ectocervix. Okay. Cis chlamydia typically infect here and causes cervicitis, cervical infection. Cervicitis. It can cause this kind of a purulent discharge from the cervix that can lead to pelvic inflammatory disease, PID, pelvic inflammatory disease. This infection can ascend like this way and go to the tubes and damage the tubes and ovaries. That is called PID. And when you have chlamydia cervicitis, it can cause post-coital bleeding. Post-coital bleeding. Post-coital bleeding. What is post? Post taking in name. After. Post means after. Coital. What is coital? Sex. What is bleeding? Bleeding following sexual intercourse. Post-coital bleeding. Chlamydia cervicitis, remember that one, it will be important for your questions later. Chlamydia infection is one of the differential diagnoses. What are the other differential diagnoses for post-coital bleeding? Following sexual intercourse, patient is having bleeding. What is the first thing that you have to suspect?
Cervical cancer.
Cervical cancer, yes, of course. Because if there is a cancer here, the poor husband doesn't know about cervical cancers. So he doesn't know. If something happens, this cancer can be traumatized and it can cause bleeding. So if someone having post-coital bleeding is very significant, you have to strongly suspect cervical cancer. Cervical cancer, cervical polyp, and the other thing is chlamydia cervicitis. Chlamydia cervicitis. And the serious thing is about 70% of these patients are asymptomatic. Even though they have the chlamydia, they don't show clinical features. Okay, so easily that can transmit to another person, a partner. Chlamydia. Okay, Daru. And chlamydia can cause Reiter's syndrome or Reiter's syndrome. In medicine, you will have heard of this syndrome, Reiter's syndrome. So this is one of the differential diagnoses. Reiter's syndrome. Chlamydia can cause that. And the other thing is that when there is chlamydia, here there's a disease caused by chlamydia, right? This is the abdomen, this is the diaphragm. Here you have the liver. Okay? Because of the chlamydia, you can get adhesions formation in this perihepatic area. In this perihepatic area, you can get adhesion formation. Adhesion formation. That is called Fitzhugh-Curtis syndrome. Fitzhugh-Curtis syndrome. The name is given in your handout. Fitzhugh-Curtis syndrome. Fitzhugh-Curtis syndrome. So Fitzhugh-Curtis syndrome, it can cause. Because patient can get severe pain around this perihepatic area, right? This area, patient get the tenderness and the pain, okay, because of this chlamydia. How will you diagnose chlamydia? To diagnose chlamydia now, you have to get a swab. From where you have to get a swab? This is also a question. Now, swab, there are two types of swabs you can get. You can get a swab from the high vaginal area. From this area, you can take a swab. That is called high vaginal swab, HVS. High vaginal swab. Okay, high vaginal swab. Or else, Darwin, you can get a swab from the endocervical region. Endocervical swab. So, if you are suspecting chlamydia, to diagnose chlamydia, you have to get endocervical swab. Remember this question. Not high vaginal swab, Darwin. You have to get endocervical swab. To diagnose other conditions like bacterial vaginosis, gonorrhea and all, you can do the high vaginal swab, but for chlamydia, it should be endocervical swab. Endocervical swab. Endocervical swab, you have to do a specific test that is called NAAT. Nucleic acid amplification test. Nucleic acid amplification test, NAAT. To diagnose chlamydia, you can use endocervical swab or urine. Even with urine, you can purify this bacteria. Chlamydia, you can purify from the urine. So, on urine sample or endocervical sample, you have to do nucleic acid amplification test. Nucleic acid amplification test. When it comes to gonorrhea, chlamydia and gonorrhea. Gonorrhea is not common like chlamydia, however, it's also prevalent. Oh, sorry, one more thing. When a mother is having chlamydia or gonorrhea, during the birth passage, the baby's eyes can be infected with chlamydia or gonorrhea. And baby will be born with all the eyes, both eyes are closed with this crusted secretory material. This is called ophthalmia neonatorum. So ophthalmia neonatorum are complications of both gonorrhea and chlamydia. Remember. So it's a serious infection to the baby's eyes. Baby's eyes. Then there was gonorrhea. When it comes to gonorrhea, right? This is obligate intracellular diplococci. What is diplococci? If you see this picture carefully, Darwani, you can see these are not single bacteria. They're always like couples, couple behaviors. They are always in couples, right? Diplococci. Within the cells as a couple, they always survive as a couple. Right? This is called intracellular diplococci, double diplococci. This is typical of gonorrhea. Typical gonorrhea in the men causes this, milkmaid like secretion, thick whitish secretion. So girls and boys, next time when you eat milkmaid, think about gonorrhea. Same appearance is same. Thick secretion. Okay. In a woman, it can cause the same kind of a secretion and PID, pelvic inflammatory disease. Management is single dose of ceftriaxone. Ceftriaxone, 20 generation cephalosporin. Single dose of ceftriaxone. Single dose of ceftriaxone. Then, human papillomavirus, HPV. So this infection will be discussed later in detail again when it comes to cervical cancers. But for the time being, please remember, human papillomavirus is another DNA virus which can cause viral warts. There are various serotypes of HPV, right? There are various serotypes of HPV. HPV 6 and 11 causes viral warts like this. Benign warts. 6 and 11. Whereas 16 and 18 mainly are called oncogenic viruses. Oncogenic viruses. Oncogenic means that only cancer-causing viruses. They can cause cancers. Cancer-causing viruses. What are the cancers caused by 16 and 18? Typically cervical, vulval cancers, anal cancers, okay, anal cancers, laryngeal cancers, vulval cancers, laryngeal cancers associated, I don't know. However, laryngeal cancers are also, some of the laryngeal cancers are also caused by HPV 16 and 18. It's not only cervical cancers. Okay, so they can cause, these are oncogenic. Actually, oncogenic type 16, 18, 10, 31, 33, 35, like the various subtypes are there. Out of those, 16 and 18 are the commonest and most virulent. Most virulent. Japan multipilla again. So you can see here, right, these viral warts, right? It's very embarrassing and embarrassing condition to the patient. Okay. The problem is extremely difficult to treat these patients. Even you burn them out and they can reappear. Okay. Recurrence is very common with these viral warts. For the preventive purpose, actually, Darwo, you have HPV vaccination. HPV vaccine is available for the prevention of these HPV related problems. Vaccine, you have two types of vaccine for HPV: quadrivalent and bivalent vaccine. Quadrivalent vaccine and bivalent vaccine. Quadrivalent vaccine, Darwo, quadrivalent vaccine will cover, sorry, bivalent vaccine will cover only 16 and 18 oncogenic types. Okay, this bivalent vaccine will cover only cancer-causing types, oncogenic types, 16 and 18. Whereas quadrivalent vaccine will cover 16 and 18, 6 and 11, the benign types also will be covered by this quadrivalent vaccine. Quadrivalent vaccine will cover everything. So when I say there's a vaccine for HPV, girls are smiling on over here. There's a vaccine. But what is the dark side of this vaccine? The vaccine, you have to get the vaccine before the first sexual exposure. Right? So ideally speaking, HPV vaccine should be taken before the first sexual exposure. Before the first sexual exposure. Okay, Darwani, right? So this is regarding HPV. Shall we discuss about bacterial vaginosis? Bacterial vaginosis. Remember, bacterial vaginosis is the commonest bacterial vaginal infection. It is not only caused by a single agent, but by multiple agents in combination, not a single germ. Multiple bacteria, gram-positive and gram-negative and anaerobes. They causes typical a profuse, smelly vaginal discharge. Now, Darwani, when we come to this vaginal discharge, almost all women, especially during their reproductive age, they will have some kind of a vaginal discharge. They will have some kind of a vaginal discharge when they are young. So this physiological discharge, they do not have a color, no color, no smell. It's like watery, no smell, and it doesn't cause any pruritus valvi. It doesn't cause itchiness involving the vulval region. So this physiological discharge, Taro, do not have a color, it's non-offensive, and do not cause any itchiness. Whereas a pathological discharge will have a color, either blood stain, yellowish, greenish, some color, and smelly, and it can cause pruritus valvi, itchiness involving the vulval region. So this discharge, bacterial vaginosis, also so profuse, frothy. You can see the frothy appearance in this picture. I don't know whether it's clear to you all, right? It's frothy. You can see the bubbles here, frothy appearance. Okay, it's profuse, frothy, and smelly discharge. This is the commonest discharge, pathological discharge you will get. Profuse, frothy discharge. Profuse, frothy discharge. Then how we do diagnose this condition? There are various things that you can use to diagnose the condition. One is that you take a sample of this and put it under the microscope. When you put it under the microscope, this is a typical feature. This is called clue cells. Clue cells are, you will see the normal epithelial cell densely covered by bacteria. So the cell will be there, like the epithelial cell will be there, which is covered by the bacteria, densely covered by the bacteria. This is called a clue cell. If you see a clue cell, that is characteristic of bacterial vaginosis. So they cause frothy, profuse discharge and clue cells. And the other thing is that if you take a sample of this secretion onto a glass slide like this way and add a drop of potassium hydroxide, it will emanate ammonia smell. So if there is ammonia smell after adding KOH, it is also characterized bacterial vaginosis. So clue cells and adding KOH, you eliminate ammonia smell. Profuse, frothy discharge is characteristic of bacterial vaginosis. When it comes to vaginal pneumonia, what is the acidity of the vagina? Vagina, is it acidic or alkaline? Normally, vagina is acidic. That's how the people say. Why it is acidic is because you know the vaginal epithelium when you are young contains what? Lot of lactobacillus is there. Lactobacillus is one of the commensal bacteria, important bacteria to the vagina. Now the people think, the girls think the vagina is the most sterile part. But we know vagina contains all the organisms under the sun. Gram-positives, gram-negatives, lactobacillus, everybody is there. So this lactobacillus produces lactic acid. Because of the lactic acid, vagina has an acidic pH. Some acidity. Normal vagina has acidic pH. Okay. Due to some reason, if this import, now when you have this acidity, that will not allow the harmful bacteria to grow. It's protective. The vaginal acidity is protective for a girl because it prevents the pathogenic organisms developing here. It's a barrier, kind of a barrier, chemical barrier. But due to some reasons, say for example, if you take long-term antibiotics, strong antibiotics, broad-spectrum antibiotics, they may kill these important lactobacillus. When the lactobacillus is being killed, they can't now produce lactic acid. So what will happen to the vaginal pH? pH will go. Acidity will go down. pH will go up. So when this pH rising or the acidity is dropping, that is a favorable environment for this organisms to cause bacterial vaginosis. So Darwin, right? When these important commensal bacteria are destroyed, it can predispose to bacterial vaginosis. So people with bacterial vaginosis, when you check their vaginal pH, pH is high or the acidity is low. So those are the characteristic features. Those are the characteristic features of bacterial vaginosis. What are the characteristic features, Darwin? What are the characteristic features? Clinically, they cause profuse, frothy vaginal discharge. Microscopically, you can see two cells. When you add KOH, it emits ammonia smell. And when you check their pH, vaginal pH is high, or the acidity is low. Remember about these features. Management is metronidazole. Metronidazole is the management for bacterial vaginosis. Okay, right? That is about bacterial vaginosis. Vaginal candidiasis. Normally, in pregnancy is a state where your immunity is low. So when your immunity is low, you are predisposed to get infections like vaginal candidiasis. So this is very common during pregnancy, and when you have diabetes, when you are on immunosuppressive treatment, you can see this vaginal candidiasis. The picture on your left-hand side is an open mouth. Is that open mouth? No, this is inside the vagina. So this picture is inside the vagina. You can see a thick curd-like material within the vagina. Curd discharge. It's a fishy smelling curd discharge in the vagina, that is vaginal candidiasis. Usually caused by Candida albicans. Candida albicans. For your MCQ purposes, Darwin, usually candidiasis is not sexually transmitted. Not sexually transmitted for your MCQ purpose. But practically, when you treat these patients, you have to treat both partners, both male and the female partner you have to treat. Otherwise, you can't cure this problem. So vaginal candidiasis during pregnancy, it's a common infection. Usually, you are treating with local antifungals. Local antifungal. You don't use systemic antifungal because in pregnancy, you use just local antifungal. It causes a curd-like discharge. Curd discharge. So next time when you eat curd, think about candidiasis. Next time when you eat milkmaid, think about something. Then finally, Trichomonas vaginalis. This is a protozoa, not a bacteria, not a virus. It's bigger than that. It's a protozoa. You know the protozoa. You can see this flagellae. There are 2, 4 flagellae, right? Flagellated organisms. Like amoeba, this is called Trichomonas vaginalis. Typically, this causes greenish vaginal discharge. Greenish vaginal discharge. Greenish vaginal discharge. greenish vaginal discharge. If it is a greenish discharge, that is usually Trichomonas vaginalis. And characteristically, on the cervix, it causes what is this called strawberry cervix. Cervix is like a strawberry. Strawberry cervix. It can cause strawberry cervix. So the strawberry cervix characterized by Trichomonas vaginalis. Diagnosed by you take a sample of this discharge and look it under the microscope, then you can see this flagellated organism. Again, management is metronidazole. Okay, so Darwani, today we have discussed very important topic as far as your exam is concerned, right? Loads of infection. We have discussed syphilis, we have discussed hepatitis B, we have discussed HIV, right? Herpes, chickenpox, rubella, PAHO-B19, chlamydia, gonorrhea, HPV, vaginosis, candidiasis, and Trichomonas vaginalis. Right. So only one more infection to be discussed, that is Group B streptococcal infection. I will discuss with the questions right in later GBS infection. It's nothing much. So everything else is covered. So this is a hot topic. These are hot topics for your exam, especially for MCQs. So please go through your handout, Daru. Additional informations are given there, right? If you have any doubt, you can always contact me. Thank you very much for joining today. Those who wish to join with my classes, you can join. You can contact my assistant, Dr. Chandika, and you can gain the information. And if you have any doubt, you can always clarify it, right? So, yes.
So can I ask a question?
Yes, sure.
Sir, so in intrauterine blood transfusion, so how can we check the ABO compatibility of the feed?
There are ways, Daru. Now, ABO compatibility, initially what you can do is, you can do what is called chordosynthesis. That means under ultrasound guidance, you can puncture the umbilical cord and take a sample of blood, and then you can see the baby's blood group. You can confirm it. And same time, you can do the PCV assessment, packed cell volume. This is too much for your list. Since you asked, I'm giving this answer. Others, don't worry, right? So you puncture the umbilical cord under ultrasound guidance and take a sample of blood. And there you can check the baby's blood group and you can check the PCV or the hematocrit. If you know the blood group and if you know the PCV, then you can calculate the amount of blood that is necessary. You calculate that volume, and again you have to puncture the umbilical artery, and along that you can give the blood transfusion to the baby. It's not easy. It's a challenging process, right? But can be done. Okay?
Okay, sir. Thank you so much.
All right. Yes. Any other questions, Daruni? Any other questions that you want to know? Anything that is not clear? So I will make sure 100% if you join me in the classes, I will cover the syllabus in advance as before what I have done so far, right? So I will cover your syllabus and I will do adequate questions, number of questions, and I will make sure that you will be fit and ready for your exam. Okay. Again, thank you so much for joining today. And if you all have any doubts, you can always clarify your doubts with me, right? And yes, thanks again and have a good day.